Dr. Joshua Black will share two presentations on population survey methodologies, starting with Frankenstein surveys, data fusion to estimate behaviors for rare populations, and a second presentation titled In Measurement We Trust, Psychometric Validation of Survey Items. Dr. Black is a multidisciplinary scientist integrating data science and biostatistical techniques into modern drug use epidemiology. He is the lead statistical scientist at Rocky Mountain Poison and Drug Safety, and he leads population health research using online panels, high-dimensional statistical methods, and generative artificial intelligence. He is a principal investigator and co-investigator funded by FDA and NIH. Dr. Black joined RMPDS in 2017 after training at the University of Denver School of Natural Sciences and Mathematics, where he earned his PhD in biophysics. He was further trained in a joint postdoctoral appointment at the Department of Engineering and Pharmacology at the University of Colorado. Let's welcome Dr. Joshua Black to the stage.
Thank you, Kate. So my first talk today is titled Frankenstein Surveys, because what I want to show you is a novel method we've developed to take two different surveys and combine them together in a way that generates valid estimates towards the general population. My talks overall fall under this theme of validating opt-in online panel surveys. This is a type of study that is being used far more often nowadays and is a type of study that we at RMPDS use quite often. This first talk focuses on sample validation. And our goal here is to ensure the samples collected in a way that is a faithful representation of the target population. Are we getting the right people, and are they telling us what we need to hear about substance use? Health professionals use population health data to guide intervention, development, and rollout. And the primary goal often is to make an estimate generalizable, which means the estimate that's created represents the target population, because you can't sample the entire population, so you take a smaller sample to represent that. Larger surveys measure drug use prevalence very well, but they fail to measure individual detailed behaviors. Our own NMERX survey measures something like 50 to 60 different drugs, and not all of those drugs are we able to provide the detailed behavioral measurements that are necessary to guide policy. Psilocybin, for example, in our NMERX survey, we only ask about general prevalence. I couldn't tell you more detailed behaviors about setting, reason for use, or dose. This gap is filled typically by smaller surveys that measure more detailed behavior very well. They have a targeted population. They only want to look at, say, one group of individuals using one type of drug, and they can spend a lot more of the survey measuring the details of how, why, where, and when a person used. But the challenge is making that smaller survey in this figure, the green box, look like the general population or the black box. We realize that this smaller survey is actually just a subset of our larger survey. That green box of yellow individuals or pictograms is equally represented in our larger survey. We just don't have that detail. So there has to be some way to combine the two data sets together for stronger inference. And that's the goal of this presentation, is I want to demonstrate a novel method that fuses these surveys together, enriching information content for national estimates. We're going to use a process called data fusion. And this is a statistical process where one data source is combined or integrated into another data source. Fusion occurs by adjusting all the factors that would cause differences in selection between the two surveys. Why someone takes the green survey is different than why someone would take the blue survey, and we have to adjust for those differences. Once we have that green to blue transition corrected, the inference from green all the way to black would be valid. We do this in a two-step serial process. We're going to make two different adjustments to the data. The first adjustment is fusion or transport weighting, which corrects for the between sample selection differences. We're going to make adjustments so that the green survey looks like the blue survey. Then we want to make benchmarking adjustments that corrects the overall selection bias back to the general population. We're using an online panel, which has its own selection bias, but really any survey nowadays has to make some kind of model-based selection. Even large population surveys like NSDA and NHIS have to contend with non-response bias. NSDA this year had an 11% response rate, and there's a dependence on a model that adjusts for non-response in the same way that we're adjusting for composition and exchangeability differences in our sample. These combined adjustments are represented as analytical weights, and those weights will correct for the selection along the pathway from green to blue to black. The full statistical details, I'm not going to show you any equations, so don't worry about that. But if you want, we can send you the poster that we presented at the Society for Epidemiologic Research. My colleague, Dr. Rockhill, presented that, and we won Best Poster. So our full publication is in process. So which surveys are we fusing? We're going to fuse our insight survey that Andrew described earlier. This contains that more detailed information about how an individual is using the various psychedelic substances, reason, setting, adverse events. We're going to fuse that on to our long-standing, well-established NMRX survey, which has that statistical design that provides the valid, generalizable estimates. To do this, we go through a 5-step process. I'm going to walk through each one of these steps, but overall what we do is first we find an analogous sample population, basically who is in the insight survey that is also present in the NMRX survey. Then we're going to iterate across 2,000 different weighting schemes and pick one. We're going to check the internal consistency, basically make sure that the fusion process didn't perturb the internal sample. Then we're going to check external validity. After fusion, does our survey generate estimates that are very similar to national benchmarks? I'm going to benchmark against 4 different national probability surveys. And then I'm going to show you one slide of results about reason for use. So unsurprisingly, the sample by itself is biased. If we just look at the insight unadjusted sample, this population is disproportionately female, earns higher amounts of money, is generally less healthy, and uses more drugs. If we just use the small sample to make inference, it would incorporate all of these compositional biases into the final estimates. And so we have to choose a weighting scheme that corrects for that internal difference. We iterated across 2,048 different sample schema, and we defined bias as simply the difference between our anchor survey in our NMRX and the weighted combined fused data insight combined together within NMRX. Overall, this transport bias after we picked our weighting scheme was generally quite small. In this figure on the right, each green dot is one of the 2,000 different schemes, and the black diamond is the one we picked. Demographics were really no different, 0.09 percentage point difference, and this is unsurprising. These panels they start with good demographics essentially, and so whatever sample you pull from them, the demographics are probably going to look pretty good. However, the health metrics and the substance use metrics both shifted a bit more. After weighting, our health metrics had a residual bias of 0.35 percentage points, and the substance use bias only had a 0.22 percentage point. So while bigger than demographics, still less than half a percentage point difference between the two samples. We had to use multiple domains to make this weighting work. We can't just use demographics. Demographics plus health plus substance use and a separate metric on trust were all necessary to reduce the bias as much as we were able to do so. In this fused sample, when we compared the internal metrics of the smaller group using psychedelics in the fused sample versus the anchor sample, the internal metrics looked quite good. Overall, differences were less than 5 percentage points across different substance use metrics. Then we checked for external validity. After fusion, the final error in the sample got quite a bit better. Demographics, again, didn't really change, and they weren't that off anyway. Originally, the unweighted error against external benchmarks was 1.8 percentage points. After error, it increased ever so slightly to 1.9 percentage points, which I think this is just error. It's a 3% increase. Health and substance use decreased quite a bit. Health went down from 7.3 percentage points down to 3.4 percentage points, a 53.7% decrease in the overall error after weighting. Substance use also improved, but we had one outlier. And as you look at the figure on the right, you can see cannabis, methamphetamine, cocaine, heroin, all the methods, the estimates improved quite a bit. The open circle was our unweighted survey. The closed circle is the weighted survey. And all of those estimates got better, closer to the benchmark in the triangles. Alcohol was an outlier, and that's because our measurement was different. I include it here because in our pre-published SAP, we included that as a metric, and so I want to show both for transparency. When we took that outlier out, our unweighted error went from 6.03 percentage points down to 1.55 percentage points, a 68.3% decrease in the overall error. And so after our weighting is applied, our overall error across 15 different metrics was less than 5 percentage points difference between our survey and our methodology and these national probability-based benchmarks. Now that we have a survey that is faithfully representing the sample that we want to represent. We estimated the national reasons, estimated reasons for using different psychedelics at the national level. Whether it's psilocybin, LSD, or MDMA, over half the sample used recognize their use as trying to improve themselves, connect themselves to others, or or improve their connection to nature. So it was a very self-motivated self-improvement, and most of the sample recognized their use as falling under that paradigm. Only about a third saw their use as treating medical symptoms, whether it's psilocybin, LSD, or MDMA, with psilocybin being the largest. About 30% or so of the sample said that they used the drug to treat a medical symptom. And overall, regardless of what their medical or self-improvement reason was, most people still consider their use as the reason that they used was for some recreational reason, whether it was for fun, curiosity, or to improve sex. So there's I think, even at the national level, recreational use is still quite prominent, but it also is present alongside individuals recognizing their use for self-improvement or medical symptoms. The strengths of this approach, the primary strength is that we're overcoming convenience sample limitations. We expand the impact of small studies by creating a statistical pathway from a convenience sample to national inference. Our approach is a mixed theory and data-driven approach. We started from understanding the theory of selection bias, but we use data to make decisions. We also have a multi-domain bias reduction. Our approach didn't just improve demographics, we improved health and substance use as well. The primary limitation is that we can't overcome positivity bias. People who aren't in the sample, I can't weight them. So people who don't use the internet are never going to be in our sample. I think this bias is ultimately small, but we're still working on other research to show that this bias is small. Measurement differences are going to persist. So the way we measure an item is going to be different than the way other benchmark surveys measure those same items. We saw this with alcohol, and then my next talk is going to really focus on how to approach measurement validation. And finally, there's going to be subpopulation misalignment. No two populations are the same, and so perfect alignment is likely never going to happen. But we want to be able to show that our ultimate bias is quite small. So to conclude, we've presented a novel study design, which we're calling the Fuse Survey Study Design. This enriches information content. We're not just adding people to the sample, we're adding people with more information. These are questions we didn't ask on our main survey, and we're able to fuse that on in a horizontal way. There's more people in the sample who have more information that wasn't there present before. We overcome convenience sample limitations. Naive samples are highly biased, and even rigorously collected probability-based surveys have to contend with selection bias, usually through non-response. And we're doing the same. The residual selection bias was small. We used 4 national benchmarks, and we had multi-domain adjustments showing less than 5 percentage points at the end of the day. And overall, individuals who use psychedelics to treat symptoms was a minority. About a third recognized their use as treating a symptom. That very well could be more people are treating something, they don't recognize it as treating a symptom, but I think the recreational paradigm where people use for fun or curiosity will predominate for years to come. So now let's move on to my second talk, which I've titled In Measurement We Trust, which this talk focuses on the individual survey questions and how we show the validation of those individual questions. Here, we want to make sure that our measurements are accurate and they represent what researchers intend it to represent. And a quick caveat before I proceed, reliability is also an important psychometric, but I'm not covering it here. I'm only focusing on validation. So every question in a survey or an item in a survey is a measurement. If you think about age, you can measure age in many different ways. You can read my birth certificate. You can take some blood and measure the telomere shortening in my DNA, or you can ask me. And one of those 3 is going to be far more accurate than the other 2 and save you a lot of time. High quality measurements and surveys are grounded in both theory, do you understand what the question is supposed to be doing, and statistical evidence. Does the question actually do what you want it to do in a real world performance situation? And so my goal in this second presentation is to outline the major methods and describe how RMPDS approaches psychometric validity. There are 6 types, kind of grouped together into 3 ways. First is face validity and content validity. This is a qualitative driven approach where you want to understand the overall content of a question and whether respondents themselves understand the content of that question. Convergent and divergent validity are related. These are two validation methods that show the content of the item tracks well with other validated survey metrics. And then concurrent and predictive validity are two methods that show the item works well in multiple different contexts, that it's transferable across different sampling paradigms and across different outcomes. So we start with face validity. This is the question, do experts like the item? Face validity is informal, but it's an essential first step. If you only do face validity, it's the weakest form of validity. But it is an initial consensus that an item appears to measure what it is supposed to measure. And it's invoked when someone says something like, that doesn't look right. You can be more formal with face validity where you seek external counsel or you use items from other well-established surveys. Both of these are very common. With our Insights survey 2 years ago, we enlisted an expert panel to review our questionnaire. We had a panelist with peer support experience, a panelist with lived experience using psychedelics, and a Colorado State health employee who looked at our survey. They read the questionnaire and took a pilot version of the survey online and provided us with written comments and inline suggestions. They identified gaps in adverse health events, helped us reword items to make sure we're asking good questions about health benefits, and helped us generate nuanced, evolving lists of drugs to make sure we're asking questions the right way that people want to understand them. This helped fill in gaps in our research team with experts who have different kinds of experiences and is a foundational step in validating a questionnaire. Content validity, this asks the question, do respondents understand the item and is every necessary concept covered? This is typically done through a cognitive interviewing process where you test the extent to which responses to an item cover the content that you want covered as a researcher. Respondents rephrase the question in their own words, and they help identify incomprehensible phrases. Experts may also provide a quantitative metric on whether content is essential or non-essential to be covered. The question is understood, is as intended to be fielded. So you want to show the question to individuals in the same way that you want to field the question. Interviews are time-consuming and essential, and you can complement them with online text-only versions where you ask individuals to write out in long form whether they understand a question or not. And I want to give you two examples, one where we wrote a question well the first time, and one where we had to change it after content validity. So our first question is the same question that Lindsay presented on earlier. What is your experience with naloxone, with 6 different response options? Comprehension was very high, 98.3% of the sample that we had for this content validity said that they understood the question, and within that group, 100% were confident in their answers. They reworded it with expected synonyms. People said reverses overdose, and we never said that in the question. And they helped suggest, the one person who didn't comprehend it asked us to add a definition for how naloxone works, and we're going to do that. In the second question, this one needed changes. So we're developing a module to investigate counterfeit drugs, and we originally had a question that said, in the past 12 months, when you took counterfeit drugs, what real medication did it look like? This question only had 87.1% comprehension and 75% confidence in answers. The rewording was expected, but participants were distracted by a large list of drugs. So we went back and redesigned the question to ask about drugs one at a time. Convergent and divergent validity. This asks the question, does the item correlate and not correlate as expected to other well-validated items? And so this is a simultaneous measurement. You want to test your new question with other validated instruments in the same survey. And you want to see a discrimination effect across different items. The correlation to validated scales is very strong evidence for validity. And this should sound familiar, analogous to sensitivity and specificity in diagnostic testing. This year in 2025, we reworked our diversion question because we wanted to expand the concept. And we asked a new question that says, when you used a drug in a way not directed by your healthcare provider, was it your own prescription that you used? And we correlated people's answers no to other validated scales. Here, just kind of focusing on the top and the bottom, people who said no were highly correlated to the DAS-10 question, had you engaged in illegal activities to obtain drugs? Highly correlated, but very uncorrelated to the question about feeling optimistic about the future from the WEMB-7. We wouldn't expect that correlation. And so we see a good discrimination of this item across validated scales. Concurrent validity asks, does the item align with similar measurements from other contexts? So you want new data and a new setting. Certain differences are desirable. Sampling mechanisms should be different, but you should still have the same target population. Bias mitigation methods should be different. Fielding context, online or in person, can be different. And this demonstrates the item is not setting specific, and it aggregates to the same conclusion as other data. You'll hear later in a talk about driving under the effects of psilocybin or psychedelics. And so we ask to validate if the structure works in our context. We asked, have you ever driven a car that you've drunk too much alcohol in the last 12 months? And in our context, it matches NISDA extremely well overall and across different age groups. Finally, predictive validity asks, does the item predict future outcomes? And this gives prospective strength against future measurements of meaningful outcomes. This can be longitudinal if the intent is to predict individual trajectories, or repeated cross-sectionally if the intent is for population-level assessment. Prospective validity supports both the item's validity, but also its usefulness in the underlying theory. Rick presented earlier on an increase in non-medical use, and that's the item I want to show here. Here's our full question, but ultimately this is a question about use in a way not directed by your healthcare provider. In this study, we have a cohort of our sample that returns year over year. And so I broke that up into 4 groups. One, people who did not non-medically use in year 1 and did in year 2, who didn't in either of the 2 years, who ceased non-medical use or continued it. And you see that people who never non-medically used didn't have any change in their DAST 1 year later. People who started to non-medically use, their DAST went up in year 2. People who ceased non-medical use, their DAST went down in year 2. And people who continued to non-medically use, their DAST didn't change. And we see this validated both at the person level and the group level change. And so we do think that this metric has meaningful predictive validity for future problematic drug use. And our increases that we saw earlier could be an initial sign of a shift in the use of opioids in the United States. So to conclude, validation of survey items is almost never a smoking gun validation. It happens, but it's rare. We typically use cumulative evidence across different approaches to show that an item works. But how comprehensive do you have to be? Do you have to use all 6? Is it feasible to do all of them? This is very challenging. It's very common for items to only be face validated. The risk of misinterpretation without more rigorous methods is quite high. And I think in public health monitoring or surveillance, we have a responsibility to do more with our items because we're showing changes over time and want to ensure that those metrics stay validated over time. And finally, we have to thoughtfully manage our resources to ensure the right amount of validation is conducted for both low and high impact items. I want to thank the whole team. I pulled across a lot of different studies for this project funded by FDA, SAMHSA, and NIH. I thank our funders. And also our standard disclosure from Rocky Mountain. And I want to disclose I used AI DALL-E 3 for my cartoons. Thank you.
Thank you so much, Joshua. I'm just always so proud of the reliability and validity work that the team puts in because it really changes how we interpret the results and really how those work.